Hi friends, welcome to Charcos. I'm Dr. Seema Balian, the founder and director of Charcos. Charcos is a healthcare recruitment and training company with over 15 years of experience in providing turnkey solution for training and recruitment needs for the nurses, doctors, and AHPs such as radiographers, occupational therapists, ODPs, and many more. OSCE training for all fields of nursing such as adult nursing, mental health nursing, pediatric nurses, midwifery, and learning disabilities. OSCE training is available in India as well as in UK. Orientation for life in UK, OSCE exam bookings and the logistics bookings, excellent pastoral care. Our state-of-the-art learning platform includes reading materials, videos, quiz to enhance your learning and equip you for a positive and a better outcome. For more information, please visit our website www.charcosglobal.com. Our Facebook page, Instagram, and LinkedIn pages by the name of Charcos Global, and subscribe our YouTube channel. Press the bell icon for regular updates and all the information that you require. We are looking forward to seeing you on our site and being a partner in your enhanced journey. Thank you very much.
Fine then. So as we said that the next one is the shoulder dystocia. So now that we have done the normal delivery, I think that a lot of things are going to be similar. So we don't have to go explaining the things like that, what are the stages and all those sort of things. So we are directly going to come on to what is the shoulder dystocia. So tell me in your terms that what do you understand by shoulder dystocia, and have you ever seen any case of it? Fasila, you can go first, and then Mercy, then you can tell me.
I didn't experience it. Personally, I didn't experience any shoulder dystocia.
You have or you have not?
I learned about it.
Okay. But you guys have not experienced it. Okay, so tell me that what do you understand by it? What might be happening?
Usually when the head is born and the shoulders are impacted, they are unable to deliver through the maternal pelvic, through the vagina. The head is born, but as I said, the shoulders are impacted and unable to deliver.
You are right. See, what happens is that if you see the shoulders, they are going to be the widest part of the baby that is going to be coming out of the vagina. Yeah. So now that is the reason that if you see the position is like that of the baby, and that is the reason that all these movements that what we were thinking that of twisting and turning happens, because the way that our bodies are made is trying to sort of see that how easily you can come out of that narrow passage. Yeah. But sometimes the shoulders, they get stuck. Now, this is mainly the reason for this is mainly the bony reason, not the soft tissue is not the reason. It is the bones, because the pelvis is in such a way that you cannot really expand it any further. It is nothing to do with the dilatation of the cervix or anything. It is just the pelvis sort of thing. So that is the reason that it becomes a little bit more mechanical, that how and what we can do in order to relieve the shoulder dystocia and deliver the baby. Okay, but when it happens, it is treated like an emergency. And that is the reason that your scenario, when it starts in your exam, you have to say it very clearly that this is an emergency and it should be recognized early, and you need to be alerting the senior obstetricians so that they can help, and you can get early help to that one, because it's an emergency. Remember, the head is already delivered. It's just the shoulders which are now stuck. So you cannot leave it like that, and the baby has to be born quite quickly after that. Now, the reasons that could be for this one is that either the baby is very big, So like if the weight is more than 3.6 kgs, then that becomes more of a risk of having shoulder dystocia. If the baby is in the wrong position, so either the lie is not right, or the way that the baby is, the hands are folded and all that, it might not be in the right sort of position. The pelvis might be too small. The maternal pelvis might be too small, so it is not able to accommodate the baby, and or it is also possible that your position as a female, that your position is not right. Yeah, and that is why it limits that how the movement or expansion of the pelvis. So there are quite a few things. Couple of them are from the baby side, and couple of them are from the maternal side as well. Yeah, so it is so there is something which is also called, something which says is a turtle sign. So it might be something that you might see, that what happens is that the head comes out, but then there is like a pull back against the area between the vagina and the rectum. Yeah, so it is kind of emptiness happens in that area because the shoulders have not come down, and that is what is sometimes called as the turtle sign. And that is also one of the signs to see that if there is going to be a shoulder dystocia. I myself have not seen this turtle sign, or even if I would have seen, maybe I did not appreciate it at that time, so I can't explain it any more than this one. Okay, so as we have discussed, that we need to make sure that as soon as we recognize that there is a shoulder dystocia, we need to treat it like an emergency situation, and we need to get help and call all the members of the multidisciplinary team. Now, one easy sort of mnemonic that you can remember is SOAPs. Yeah, that who all should be there for if there is a shoulder dystocia, that who all are the people you should call to be in part of the multidisciplinary team. So S stands for senior midwife, O is the senior obstetrician, A is the anesthesiologist. So it is quite possible that you might have to anesthetize the female. Pediatrician, because now the baby is going to be under distress when the baby comes out. So you need to have a pediatrician at hand. And then some others, like some more of the midwives. So you might need to have a couple other people as well to help you in that. Someone who can document all of the things, someone who can check the fetal heart or the CTG as well. So you'll need quite a few people if you are in these kind of an emergency situation. So always remember that who all are going to be the part of your multidisciplinary team. Okay, do you understand this one? Yes, please. Then you also need to make sure that we explain the situation to the woman and reassure her that we need to, obviously, when you are doing, when it is an emergency, and if you are trying to sort of call these many people, the woman anyways anxious, they are going to get even more anxious. So it is important to explain the situation and to reassure. Another very, very extremely important thing is that you need to ask the woman to stop pushing. Yeah, because we do not unnecessarily want to either tie her down or to just keep on pushing, because that is going to put the pressure on the baby as well. So you need to ask her to stop pushing. You need to recline the back of the bed, remove any pillow from the behind if that is there, and you need to move the woman towards the end of the bed. Yeah. So once all of the team is over there, then you will need to do a couple of maneuvers to make sure that you try out a few things to help and deliver the baby. Now we'll learn the maneuvers over here. Yeah, and these are the things that you will need to actually tell in the real life, in the exam as well. You need to make sure that you know about all those maneuvers as well. Now, this is another mnemonic that is going to help you to understand that what all are the things that you need to do, or what is the sequence that you have to follow when you are facing a shoulder dystocia. So it is called as the helper with the double R in the end. Now, H stands for help, which we have already called. So you have already called your multidisciplinary team. E is going to be that you evaluate for episiotomy. Now, the reason why we want to evaluate for episiotomy is that we are trying to see that whether opening up the pelvis, or sorry, the opening up the perineum, whether that is going to give or make more space for the baby to get delivered. Yeah. Sometimes it is also that sometimes there is a risk of having a perineal tear. So rather than risking a tear, episiotomy is better because that is a controlled sort of tear that you are giving rather than any tear that is happening from anywhere. So sometimes we have to decide that whether we should be giving an episiotomy. Yeah? Then L is for legs. So in the legs, that your obstetrician, the obstetrician may use the Mac-Roberts maneuver. Now, do you know what the Mac-Robert maneuver is?
I read a bit about it.
Okay, I'll show you in the pictures. I've taken some pictures so we can show that one. But the Mac-Robert maneuver is that you hyperextend the legs. So what you are trying to sort of do is that you are giving or opening up the pelvis as much as possible. So that is called as the Mac-Robert maneuver. P is for pressure. So then what happens is that you have opened up the pelvis. After that, you are going to use the pressure, that you give a suprapubic pressure to try and push out the baby like that. So you give downwards and outwards pressure so that you are almost squeezing the shoulders to pass through to pass from under the symphysis pubis, because actually the shoulders are stuck at the level of the pubis. Yeah, and if they cross that one, after that it is going to be okay. Yeah, and then we are going to do some other maneuvers, the enter maneuver or the internal rotation sort of thing. So where you are trying to move the shoulders so that they can come down. And then there are the removing of the posterior arm and roll the patient. So these are another two maneuvers where called as the Jacquemer maneuver and the Gaskins maneuver. So in total, there are 4 maneuvers that you are doing. Extending the leg called as the Mac-Roberts. You give the pressure to suprapubic pressure you have to give to try and push the shoulders out. You do the enter maneuver where you are with your fingers, you are trying to rotate the shoulder, and then you remove the posterior arm, or if you are able to remove the posterior arm, that means that suddenly, because one arm is already delivered, the shoulders will fall down and you will be able to the baby will be able to be delivered because now there is more space over there. And roll the patient. So rolling of the patient is that you ask the patient to be on their fours, so trying to sort of with using the gravity to pull down the shoulders as well. So these are the 4, or you can almost say 5 maneuvers. So Mac-Roberts, pressure, enter maneuver, Jacquemer maneuver, and the Gaskin maneuver. These are the 4 sort of 5 things that you will need to understand and know. Now let us see if one by one we can see that how it is. Now, this one is going to the Mac-Roberts maneuver. So as I said, that you are going to be extending the legs. So you are going to pull the legs back, or you will be flexing them towards your thigh, and you are going to be opening up the pelvis. Try and open up the pelvis like that, so that then you make a more space over there. Yeah, so that is called as the Mac-Roberts maneuver, when the legs of the mother are pulled towards the mother, or the thighs are towards the abdomen. Yeah. Then comes the suprapubic pressure. Now you can see over here, this is the pubis of the mother, and you can see how the pressure, you are going to be putting the pressure using both your hands to push down and outward pressure. It is going to be so that you are trying the shoulders to be delivered, or this trying to push the shoulder out of from under the pelvis. Yeah, so the pressure is applied downwards to assist and dislodge the impacted shoulder. So it is done along with the Mac-Roberts maneuver. So these can be done together. See over here, you can see that it is done together. So the legs are flexed towards the abdomen, and you are trying to push and bring the baby out. So you are giving the maximum chance of the baby to be delivered by opening up the pelvis as much as possible. Episiotomy we have already discussed, so we can see that if there is a requirement of an episiotomy, and usually if we are giving an episiotomy, we give a mediolateral episiotomy, which is away from your anus or away from the rectum and all those areas, so that the tear does not goes in those parts. Then we do the enter maneuver. Now, as we see that with the fingers, yeah, the enter maneuver is that internal rotation. So you put your fingers down and you try to rotate the shoulder. Yeah, so you are trying to turn the shoulder. So when you will rotate, the upper part of the shoulder is going to try and move out. So you do the enter maneuver to try and rotate the shoulder to help with the delivery. And then we come to the Jacquemer movement. So the Jacquemer is where you have delivered the posterior arm. So you have delivered the arm. So when we are internally rotating, we make sure that with that rotation, we try and pull the arm as well to try and relieve the pressure or to give more space, because as soon as one arm is out, your shoulder is going to fall down and then you are able to move it outside. And then the Gaskin movement is that when you are turning the female into all fours, and then with the help of the gravity and the new position, you are trying to sort of just pull the baby out. Sometimes it can resolve, and sometimes, so it is, you can see that all the methods which are going to be used in order to make sure that somehow you are able to open up the pelvis and you are able to deliver the baby. And then there are few other very drastic measures that you might have to take, which are like really drastic, that if you are really, really stuck, now we have to, in whatever way we need to deliver the baby. So then there is one is called as the clediotomy, in which you both the clavicles are cut in order to reduce, because if you cut the clavicles, suddenly you are able to now move the shoulders more inward. You are able to create that more space and hence deliver the baby. Then cephalic replacement, again, it sounds like really, really drastic, that you push the head back into the pelvis and then deliver by cesarean section. And symphysotomy is that when you cut the cartilage of the pubis symphysis of the woman in order to widen the pelvis, and you are able to deliver the baby. So these are quite a few of these ones which are there. And I think that it is, you will need to read a little bit more about them. But what I would really want to tell you is that please do not get too much worried about this one. So it is not that in the exam, no one is going to ask you to try and perform all of the things. You need to just know these 5 steps. The first one is that when you are doing the Mac Roberts movement, where you are trying to flex the legs of the mother towards the abdomen to open the pelvis. Second one is that when you are giving the pressure, the suprapubic pressure downwards and outward to try and move the shoulders out. Enter maneuver, in which you are going to try and internally rotate the shoulders to sort of see if that is going to help to deliver. Then you are going to be delivering the posterior arm. So that is called as the Jacquemer movement. And the fifth one is the Gaskins, in which you are putting the female onto all fours. And you can just say that if nothing works, then you can go for the clediotomy or the replacement of the head back into the pelvis, or the pubis, the cutting of the pubis sort of thing. These ones. Symphysiotomy. Yeah. So quite a drastic sort of thing. Lots. It sounds very dramatic. Yeah. Majority of the time, it is. I would not say that I have seen many. Probably I would, in my career, I might have seen only a few. And nowadays it is getting even less and less, because majority of the time you would have already done a lot of assessments that what are the chances of a normal delivery. And cesarean section is always there, that if they feel that the baby is too big, or if the pelvis size is not good, and there is a risk of any kind of issues happening, then normally the obstetrician will suggest the cesarean section, and all of these things are avoided. Yeah, but for as a midwife, you need to be aware of all these things, and of course, in the exam also, it is going to be asked. So, any question that you have in this one, or any of the maneuver you did not understand, you want me to repeat again? Silence. Okay, so I'll take that as that you have understood it, or at least you don't have any question at the moment. Okay, so now that what we have delivered the baby, and we know that what all other maneuvers, we also need to understand that what can be the complication of shoulder dystocia. Now, of course, there is a lot of these things which are happening. There is a lot of intervention that is happening. So it is quite possible that there is a risk of having a postpartum hemorrhage. Yeah, and because there is a lot of maneuvering happening, there is also a risk of tear between the vagina and anus. So there can be a first, second, third degree tear of the perineum. Because of that, there is also possible that there might be a rectovaginal fistula as well. Yeah, then sometime it is also again at a extreme end, there can be uterine rupture, that the uterus can also tear during the labor, and the separation of your pubic bones. So that is also there, because there is the baby is trying to like one way or the other, your body is trying to push the baby out. So it is possible about that as well. So these are the things, complication which can happen to the mother, but obviously the baby is also the part of all of these things. So the most common complication happens is the brachial plexus palsy. Yeah, so because the brachial plexus is going to be there near your neck and the shoulder, and that is where, if this is the area which is involved, so the nerves which are over there, they can get affected, and that can lead to the brachial plexus palsy, or the hand might not be, or your arm might not be working properly. Fracture of the collarbones, whether the fracture happens spontaneously or whether it is sclerotomy is done, there is a possibility of the fracture, or even the upper arm bones, humerus can also get fractured. Yeah, then Horner syndrome. This can also be where your baby's eyes and face are can also be affected more because of the nerves and things which get affected. Compressed umbilical cord. Now it is possible that the umbilical cord can get trapped between the baby's arm and the pelvic bone, and that is why there is going to be a compression of that one, which can cut off the oxygen, or there might not be a good flow of blood, and then that can cause issues with the brain injury, or hypoxia, or even in extreme cases, even death as well. So these are some of the complications to the mother and the baby of the shoulder dystocia. Now, after going through all of these things, the top tip still remains the same. Stay calm, identify that it is an emergency, call for the multidisciplinary team, make sure in the exam that you are demonstrating all of the maneuvers, taking the consent, good communication, involving the woman is very, very important. Also, consider even after the delivery, you need to make sure that to take into consideration other conditions like the mother's mental and psychological issues. Physically, she might end up having a PPH or perineal trauma or episiotomy. And of course, the baby also needs to be taken care of and checked that it might be a brachial plexus injury or any other problems which might happen. So all in all, shoulder dystocia can be quite a significant event in the females and the baby's sort of journey, and it can lead to quite severe outcome as well. So we need to be very prompt in recognizing it and trying to sort of do as much as possible to have the safest form of delivery. And then really need to support the woman and the baby, because it's almost a traumatic birth that has happened. So it is important to cover up all these things as well, so that you can complete the scenario. Okay. So, any questions so far in any of in through the shoulder dystocia? Anything that you want me to repeat? Priscilla, Mercy?
Hello? Hello?
Okay, fine then. Any question that any one of you has?
I think I have to go over the notes and see if I have any question now.
Sorry, say again. Mercy, say again.
Please, I said I'll go over the notes when it's being put on the page and see if I have any question. I'll drop it.
Okay. Priscilla, do you have any question?
About the maneuver. So when you are
About
giving the maneuvers for the shoulder dystocia, so when you
yeah.
are giving a scenario,
Mhm.
so when you are delivering the baby, so will you try or you just do one of the maneuvers? You take one and you do it, or you have to analyze all of
You
it, or you choose what the maneuver you want and you do it.
you will have to show all of them. So you will need to show the macrobursts. You will need to show the suprapubic pressure. You will need to be showing the internal rotation one, and you will need to be showing the delivery of the posterior arm, and then the gaskin maneuver as well, the on all fours. So you will need to show one by one or you'll need to go through all of them. I think that for the purpose of demonstrating, majority of the time you will end up demonstrating only the macrobursts and the suprapubic pressure, because the rest of them you might not be able to demonstrate them. But you will definitely will need to say all of these things, and along with the things that yes, in if nothing else works out, then you might go for clitotomy, you might go for the cephalic replacement, and you might go for the symphysiotomy as well. So you will need to tell all these things. Any other question? Okay, so what I'll do is that I'm just going to quickly take you again through the criteria as well, so that we can understand and you can understand that what exactly are they checking. See, this is the criteria for the shoulder dystocia. Yeah, so the first thing that you will need to recognize that it is an emergency and you are going to call for help. Yeah, so you'll need to pull for the emergency buzzer, and you are going to clearly state it is shoulder dystocia and that you need the multidisciplinary team. So the team that what we have said according to the scopes. So your senior midwife, your senior obstetrician, then the pediatrician, the anesthesiologist, and some of the other midwives as well, who can help you in all of these things. So you will need to make sure that you tell all of those things that you need. Then is that you ask the woman to stop pushing, and you are going to put the bed flat and you are going to bring her down towards the end of the bed. Then you are going to do the McRoberts maneuver. You are going to apply the suprapubic pressure. You are going to be evaluating for episiotomy if it is required. You will attempt to deliver the posterior arm. Then you are attempt to do the internal rotation maneuver, as I have told you. And then is the gaskin one, that where you are going to support the woman to roll over on all fours, or verbalize the possible benefits of this change in the position. And verbally, you are going to be telling about the clitotomy, the cephalic replacement, and the symphysiotomy. Then you are going to verbalize the need for the midwife to ensure that the woman understand what has happened and chance to bond with the baby. verbalizing the maternal observations, verbalizing the importance of newborn observation, and verbalize the importance of completing all of the documents. Yeah, so a lot of verbalization, but you will need to also show all of the maneuvers you will need to show.
Okay.
Yeah, and that is the reason that it is important for you to understand all these maneuvers and how do they follow in the sequence. So anyway, I have recorded the session and I am going to be sharing the recording with you so that you can go through it again and you can understand all of them. Okay?
All right. Okay.